the Ortho PA-C, hosted by Sam Dyer. Welcome to the Ortho PA-C, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Welcome back to today's podcast, Building an Orthopedic Practice, with my guests Dr. Philip Clifford and Mattie Collier PA-C. Welcome, Mattie and Flip. Thanks for being with us.
Thanks for having us.
I'm hoping to cover a couple of topics, both starting up and managing an orthopedic practice and outpatient total joints. So let's begin with starting up your own practice. So how's it going?
Oh, gosh. I mean, we picked the perfect time right before a pandemic to open our own practice, right? I mean, independent private practice, giant city. Right before a pandemic. Awesome.
That was a hiccup that nobody plans for.
Obviously it has its challenges. Independence is a fantastic thing, but it is work. It's a situation where you learn you really have to surround yourself with fantastic people. We hired one amazing human who has made all the difference in the world. Without her, we'd be done.
Yeah, we'd be belly up.
We'd have been belly up a long time ago. We've also hired some folks that came very well recommended and lost a lot of money on them. And that was with vetting people appropriately and supposedly folks being really good. So, that's part of it. But we're actually fortunately really starting to turn a corner and doing a lot better, having gotten through the whole COVID crisis, which, as you imagine, for elective surgery, the fear that a lot of people had, whether it was going to a hospital for surgery or a surgical center, people didn't want to go outside. So it was hard. It was hard.
There's so much to think about and so much to do with starting any business, but what would you say are the top things to consider when hanging your own shingle as a private orthopedic practice?
Several things. EMR, radiographic storage of images, how to reconcile those two. One of the things that we did was we kind of combined the two. We actually purposely chose an EMR that facilitates image capture, and it's cloud-based. So we have our images, instead of being stored on a PACS, are actually stored in our EMR and can be brought back up for comparison within the EMR, so we can review images, but don't have to pay for an extra PACS. There's so many different things as far as how those two are related that actually helps. Malpractice insurance, health insurance, contracting, billing, all of that. All of those are challenges that are, if you haven't dealt with them before, it's almost a different language.
Sure. What about insurance and billing?
We are fortunate to have a fantastic billing company that, one, doesn't charge us a lot, but two, does just a fantastic job. So that's super important as well.
Okay, awesome. How have you integrated yourself into the community with respect to referring providers, patients, etc.? What makes your practice attractive to your community?
So initially when we got here, we were connected with a lady who was born and raised here and has done marketing for other groups, and she took us around and introduced us to some folks, and unfortunately that didn't really pay off despite our best efforts and being on our best behavior. But we also have just kind of gotten lucky. We had a gentleman cold call us who was a physical therapist and chiropractic doc here, and we ended up just hitting it off, and his small practice and our small practice put together 5 and 10K at the end of 2019. So that was huge, and now we're actually sharing an office space for the time being and referring each other patients. Another thing is in Florida, or Tampa rather, there's not a whole lot of providers that take Medicaid. So we're one of the only 2 practices that takes Medicaid. And we've really made a connection with a group here called Tampa Family Health. And they mostly use what's called Hillsborough County Insurance. And it's Medicaid, but it's for a year. And so it's folks that just have kind of had a bad run of luck, maybe lost their job, who knows, but it helps them stay on their feet. So we've really had some incredible people come from that insurance group. And since we're one of the only people that take it, they really helped us. And then some other physicians who sports docs also doing joints that don't really want to do joints. What am I missing?
I've sort of always tried to give back to my community. So hence the want to go ahead and take Medicaid, even though so many people are not willing to. One is it serves your community, and the other is those folks tend to be very appreciative of your care, and they got families, and those families, some of them need help too, and they might have regular insurance. So doing a good deed sort of goes a long way. I did that when I was in Durham. I was a part of Lincoln Community Health Center, and gosh, we were doing surgeries there that you weren't even getting paid for at all. So it truly was community charitable care. So your heart's got to be in the right place in medicine still, even today when we're all pushed to do more and get crushed for money. And honestly, that usually comes back to help you. There's definite referral patterns that you kind of have to try to fight, and those are tough. And a lot of times, what that actually takes is a patient hopping on the internet, and once you get enough Google reviews, which is where we've gotten in the last 5 or 6 months, it really makes a big difference. So patients have found us through the internet search. You have to attack it from several different angles, and having an online presence is important. But paying an arm and a leg for search engine optimization isn't really the best way. It's more of a long haul presence and just treating people right, and the word gets around. It takes a while, but
We actually, this is kind of my favorite thing that's happened lately. We had a lady who, well, she was referred to us from one of our patients. So patient already referred a patient. This woman is in security at the Tampa airport and sees this woman like hobbling around that hip, and she pulls out our card and is like, "You got to go see these guys. They're great."
Wow.
Spending time with folks, it really goes a long way.
Very well said. Please tell our listeners what options your practice offers patients for hip and knee degenerative joint disease, i.e., regenerative medicine, surgery, arthroplasty, bariatric surgery referral for weight loss. What options?
Yeah, we kind of do all that. So in with knees, we primarily follow a pretty routine protocol. If it's a pretty trash joint, we'll potentially try a steroid injection. I usually use that as a prerequisite. I actually won't typically inject steroid in folks whose joints look pretty good. I think in general, in our world, both intra-articular and oral steroids get overused, but maybe that's a topic for another podcast. So steroid, and then viscosupplementation. From a regenerative medicine standpoint, I'm a big believer that the magic of stem cells isn't the cellular portion; it's the growth factors that get transmitted along with them. So in the few patients that stem cells work, which is very hot in Florida, I think it's actually the growth factors. Stem cells down here range from 5 to 7,000 for an injection. The amniotic fluid, which has the exact same growth factors, tends to be about 25, 2,600 for an injection. And I think regeneratively probably works as well. We have had significant success with a number of folks who are grade 3 osteoarthritic knees, who and even one guy who's grade 4 and on some views do actually quite well with amniotic fluid injections, with even 6 to 12 months of improvement, maintaining activity levels. The cutoff we have for surgery typically is about a 42 BMI, and we try to counsel patients who are heavy. We talk through intermittent fasting and potentially combining with a healthy keto or keto-esque diet. And that's worked for a great number of our patients. We do have a really good bariatric surgeon that we refer to, and we actually have a provider that also does diabetic care, counseling, and physician-assisted weight loss. I think that's a huge flaw that so many practices. It's like surgeons are sometimes asses, and a fat person goes in there and the surgeon tells them they're fat, as if they don't crazy already know that they're fat, and then they don't help them or even offer to help them with what to do about it. So it's really kind of a shame, because it's not that hard for us to take a few minutes and try to coach them up a little bit, I probably take too many minutes, but that's my MO. So I think that's important. I think it also shows compassion, and I think you're not going to lose that patient. And I think if you treat that patient with respect and compassion and try to help them, that they're going to go home and tell their family, "Wow, this is like the first doctor that didn't just tell me I was fat and tell me to get out and come back when I'm skinny."
We've actually had a lot. Like I can't even say a handful. We've had multiple handfuls of patients that have come in, have known they were well overweight, but literally have had nobody help them. And we've built a relationship with a physician here who focuses on weight loss, and he writes a beautiful note. My goodness. But he actually tailors eating and recipes and all this stuff for them. We have a gastric bypass doc that we work with, but then a lot of it is honestly spending time with them and just spending 10-15 minutes just talking about basic nutrition or basic portion control. Or so many people don't realize that they're drinking their calories when they are drinking, sweet tea over unsweetened, or little things like that. And they come back and they get their joint fixed and they feel so much better.
Yes,
For many reasons.
It's just taking the time to do a little bit of education. Like when somebody's heavy, like, well, what's your normal day of eating and drinking like? And the next thing you know, you've found literally 1,000 calories that you can act from their diet with just such ease, and they have absolutely no idea what they're actually doing to themselves.
That's really great information. I know there's no punch clock when it's your own business. Do you have call? How do you split your time between the office and the OR, and what are your hours?
We are in the office far too much.
So gosh, that's pretty easy. So we're Tampa's an environment that typically the vast majority of hospitals don't really require call. You can take it if you want. I've sort of been there and done that, being in this business for more than 2 decades. So avoiding call and focusing on our arthroplasty patients has worked. I've sort of contemplated it, but always want to provide the best care for wherever I take care of, and there's probably better traumatologists out there. So
he's a phenomenal knee and hip surgeon, but if I break my humerus, I don't really want him touching it.
Yeah, agreed. So we don't take call except for our patients, and the way we handle that actually is a pretty simple system. It's they call our office after hours. They push 4. They leave a voice message,
get prank calls now.
and it goes via email to our Mattie and my phone, and one of the two of us will answer it. And that's literally 24/7. From a rounding standpoint, we really don't have inpatients. On the very rare occasion we do, I typically actually Mattie falls on that sword. We have a hospitalist that helps us out because, again, pretty much always if somebody's in the hospital, it's because of a medical problem. So we need medicine to be taking care of them anyway.
Yeah, we actually, so we typically are at a hospital on Wednesdays, and then we're at our surgery center on Thursdays. And we have a wonderful nurse at the hospital who I don't know what her title is, but she's like a little nurse angel, and she just keeps everybody calm and really helps us out tremendously, because I am very honest with folks. I'm like, listen, we're at the hospital, we're at the surgery center on Thursday. I really won't have time to come and see you till the afternoon. And the folks that do end up staying, they usually don't want to stay, but they know they have to stay because of whatever medical reason. And they're usually out of there before lunchtime, so they don't even wait for me. So I'll usually call them and make sure they're okay. But they're usually rip roaring ready to go.
Right now, our balance is we operate every Wednesday and every Thursday, and occasionally on Monday. And we're in clinic Monday, Tuesday, Friday. If we're not busy in the OR on like a Thursday afternoon or Wednesday afternoon, we will have an afternoon clinic. In a perfect world, we would do 4 to 5 joints every morning, 4 days a week, and start early, like 7 or 6:30, and then run clinic from 12 to 5 every day. So that's kind of what we're shooting towards once the volume gets up a little bit higher.
Flip and Mattie, thanks so much for being with us today.
Thanks for having us.
Sure, thank you for having us.
Thank you for joining the Ortho PA-C podcast.
Join us for our 21st annual meeting in Nashville, Tennessee, PAOS in the Music City. September the 6th to September the 10th, 2021 at the Omni Nashville Hotel. Check PAOS.org for details.